Okay, and welcome to the Davies Use Case webinar being presented by Cleveland Clinic Abu Dhabi on therapy plan order and optimization. This is the Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS. It is my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from Cleveland Clinic Abu Dhabi, Jennifer Schrader, Jaish Janard Hanan, and Eileen Federico. We'd like to welcome you all to the webinar today, and you can begin when you're ready. And again, thank you for joining us.
Hello, we are here to present for you a case study about therapy plan ordering optimization. This will be presented by myself, Jennifer, and our two team members, Jayesh and Eileen. We both work here at Cleveland Clinic Abu Dhabi, and we're part of the Mubadala Health Network here. We have set up the first U.S. multi-specialty hospital outside of North America, and we are motivated to cultivate a sustainable healthcare system and also support the development of Emiratis in healthcare. Our mission and vision statements, you can see that the foundation goes beyond just providing complex and critical care for the population. We are committed to supporting medical research and education, as well as providing a venue for Emirati nationals to develop their careers in the healthcare sector, both in clinical and non-clinical roles. We work to fulfill our mission from this incredible facility that we find ourselves in today. Our hospital was designed to offer state-of-the-art treatment for some of our community's sickest members. They are served by 26 operating rooms and 364 patient beds at present. We are expandable up to 496 beds so that we can continue to grow and meet the need for the demand. Cleveland Clinic Abu Dhabi is a physician-led hospital with a unique multidisciplinary model of care. Our focus is on excellence in patient care and supporting medical research and education. We aim to provide world-class, closer-to-home care for our patients, ensuring they do not need to travel abroad. We are organized around 13 institutes, including 5 centers of excellence, which include heart and vascular, neurological, digestive disease, eye, and respiratory and critical care. These institutes combine to offer complex and critical care across more than 30 medical and surgical specialties and more than 60 subspecialties. And working together, they provide an unparalleled level of care for our local and regional community. There are more than 5,000 caregivers now working at the hospital, representing more than 70 nationalities. Our diverse caregiver family reflects the diversity of the UAE population. Our efforts to support the development of the next generation of Emirati caregivers have led to our recent success in growing the number of UAE national caregivers to 18% of our workforce. In addition to the world-class care that we provide, Cleveland Clinic has a number of unique offerings. We have a raft of detailed outcomes and performance metrics that are continuously monitored at the highest levels of our organization. Patient experience is a key part of that. We pride ourselves on delivering a world-class experience from the moment our patients enter our hospital until they leave. Cleveland Clinic's guiding principle is the patient-first philosophy, which guides everything we do. This enables us to focus on delivering exceptional levels of complex and critical care and supporting people for every step of the patient journey. Innovation is at the heart of our care as we introduce new treatments, devices, technologies, and approaches to our care. The innovation extends beyond our hospital as we work with Mubadala to create an integrated healthcare network between the Mubadala assets, supporting the full provision of care as a national health service. Our patients' first approach to care combines state-of-the-art amenities with the best global clinical practices. Every aspect of the hospital was designed with the patient in mind. Our Office of Patient Experience that reports directly to our CEO provides direct oversight at the highest levels. We have extremely tight integration with our main campus in the U.S. with regular video conferences for physicians to collaborate on cases. We have also built the world's first globally integrated healthcare network. When a patient comes to us, they have access to 57,000 highly skilled medical experts around the world. There are three factors that make a facility like this possible: the support of our nation's leadership, which we have, the need within the community, which we are addressing, and a strong partnership, which is what we have with Mubadala. Collaboration since day one, planning the site and set up together. Now we are working with Mubadala to create an integrated healthcare network between Mubadala assets, supporting the full provision of care as a national health service. We are a leader in terms of the quality and complexity of care, from advanced regional first treatments, such as robotic mitral valve repairs, to bronchial thermoplasty, remote heart monitoring, as well as 24/7 epilepsy monitoring. Fulfilling our promise to deliver world-class healthcare in the UAE, including the development of a multi-organ transplant program. We have performed our full first heart transplant, our full first liver transplant, the first lung transplant, the first double lung transplant, and the first successful related living donor liver transplant, as well as 12 kidney transplants over the past year. UAE's first robotic hysterectomy, first robotic myomectomy, first endoscopic sleeve gastroplasty, and cardioband mitral valve repair have also been performed. In our role as a teaching hospital, we provide a foundation for the future development of the UAE's medical sector, allowing the next generation of UAE national physicians to train and develop their skills. We continue to expand that role, launching a residency program, physician internships, and preparing for our first fellowships. Around 55 academic research projects ran around the hospital in 2018. Other growth areas that we've launched at Cleveland Clinic is that we have opened a new branch in Al Ain, which is located within the Emirate of Abu Dhabi. We also have new outreach to Northern Emirates, more opportunity to grow moving forward, as well as introducing more oncology treatments that has already started in 2018. We are attaining Arab board accreditation to begin our physician residency programs as well. This will enable the nurse to release we're now directly into the thing. Okay, so the problem identified in this therapy plan was that upon clinic activation, there was no effective computerized order process for patients requiring recurring therapy treatments in the Infusion Center. This then negatively affected the clinician workflows as well as caregiver and patient satisfaction. The current agreed-upon process between the Infusion Center and pharmacy is that medication should be received and able to begin administration within 1 hour. The initial length of stay prior to the implementation of this process was 142 minutes, which when reduced by administration time leaves 112 minutes of waiting time simply for medication arrival. Some of our goals set will enable the nurse to release medications immediately once the patient is clinically assessed and cleared for treatment. And through IT innovation, the clinicians would then be able to plan, release, and administer medications effectively for those patients that require treatments with us in the Infusion Center. Orders would also be readily available when the patient checks into the clinic, and medications would be previously signed by the physician in order to be ready for, medications would be previously signed by the ordering physician for administration. Some issues that we have was that there was no efficient ordering mechanism in place for patients requiring treatments at the infusion center. And this then increased time spent by the nurse waiting for an active order to release. The patient's length of stay was then also impacted because it increased as well. The impact was that this was a major dissatisfier with our patients due to the increased length of stay. Caregiver dissatisfaction was also present due to the unavailability of active orders upon check-in to the infusion center. This included not only nurses, but physicians and pharmacists as well. This was found to be an important problem because in order to provide the Cleveland Clinic Abu Dhabi standard of quality and innovative healthcare, it was necessary to receive a more efficient method of ordering. It was necessary to create a more efficient method of ordering medications for recurring treatment times in order to reduce the visit times, and this would then positively transform service quality, continuum of care, and improve overall patient and caregiver satisfaction.
So for the solution strategy for recurring treatment orders across multiple encounters, this was identified by the joint efforts of the following stakeholders. First is the clinical team, which is our hematology physicians and infusion nurses. They are our subject matter experts that help us determine the clinical workflow and the contents of the actual build. And the other team is the IT team, which is comprised of IT EMR, our technical team who is responsible for completing the system setup and configuration changes, our EPIC representative who provided support on solution strategy and implementation, and informatics who managed requirements gathering, clinical governance, training, and support. Through the collaboration between our stakeholders, the solution identified was to implement the functionality of therapy plans. Basically, therapy plans are a set of orders that clinicians have determined to be appropriate treatment for a given condition. This means that orders can be placed and signed in advance and released when ready to be administered. It can include medications and procedure orders. Clinicians can also edit therapy plans based on the patient's specific needs, and this can be done for a specific treatment day or for the therapy plan in general. In addition, one of the main benefits of using therapy plans is that it tracks changes in order details over time, providing a seamless view of a patient's overall treatment journey to our clinicians. So for the next two slides, these are the key activities that happen during the solution and implementation process of therapy plans. For the solution analysis, the IT teams collaborated to identify the best solution to the existing problem. Informatics has presented the problem to our EMR team, and EMR has worked with our EPIC representative to discuss the appropriate solution. In parallel, informatics has also taken the feasibility request through governance process approval. For foundation demo, after identifying therapy plans as the solution and taking into consideration its benefits and limitations, a foundation demo was conducted with the clinical stakeholders to provide an overview of its functionality and how it can address the issue on recurring orders. For the mock build, after the clinician has approved the functionality and has agreed for therapy plans to be implemented to optimize our current ordering workflow, a mock build was initiated in our non-production environment. For the actual system build, requirements gathering, we've conducted several meetings between clinicians and IT teams, and this is to identify which orders are needed for the protocols and which navigator in system build changes needs to occur while taking into consideration their existing workflow in EPIC. For user acceptance, after completing the build in non-production environment, a validation session was conducted with the clinicians to make sure that the new workflow is clinically appropriate and meets the needs of the organization. The user acceptance process included clinicians having all of the tools they need in their therapy plan navigator, verification that the therapy plan protocol is available and orders are correctly configured, such as the dosing and the frequency of meds, and then also to make sure that clinicians have the ability to quickly access therapy plan information in reports when needed. For training, a walkthrough was conducted not only to clinicians, but to trainers and site support specialists who are on the floor supporting our clinicians. The training was comprised of two parts. The first is for the physicians. It is for them to be able to navigate and apply the therapy protocol seamlessly, to be able to add and edit orders to customize the plan, and to sign the orders. The second part is for the nurses, for them to view and release orders with a click of a button, and to complete and cancel treatment days when needed. In addition to the walkthrough that was provided, a supplement training material was shared to stakeholders for reference. For the last phase, which is the pilot implementation, therapy plan functionality was first implemented in hematology and infusion clinics, and the first therapy plan protocol introduced was iron sucrose. For the implementation timeline, as mentioned, it was first introduced to hematology physicians and infusion nurses, and was later introduced to other departments such as digestive, pulmonology, nephrology. Although the functionality was implemented July of 2015, the first iron sucrose therapy plan protocols was utilized on October of the same year. This delay was due to the extensive training that was conducted in each of the departments to ensure that clinicians understand the basic workflow and the benefits of the therapy plan features prior to use. In addition, we've also provided clinicians practice opportunities in our play environment to solidify their knowledge with the new functionality. As for the latest rollout, which is June of 2018, nurse practitioners were provisioned to place therapy plan protocols.
After the implementation of the first therapy plan, the iron sucrose one, so we got multiple requests for developing therapy plans. So we developed a template for requirement gathering. So the template has multiple pieces into that. The initial part includes capturing the details of the basic details, like when the plan needs to be reviewed, what should be the protocol name, what should be the message system, or what should be the specific message needs to be received once the plan is laid for review, and followed by the order details, and which includes the order name, its interval, and what should be the minimum separation days between each order, and how long it can be deferred in days, and etc. And most often, request of a new therapy plan protocol is nurse initiated and is closely collaborated with the IT team for requirement gathering. So final validation is completed with physician input before production implementation. So before implementing the therapy plan, physician usually places orders from the orders for admission navigator in Epic. So it created some issues. For example, if physician wants to place 5 visits of iron sucrose, and he will place 5 doses, and this created some delays in completion of the patient visit, because after the first visit, the order will go cancelled once the encounter is closed. So this resulted some cascading effect on future patients being seen at their scheduled appointment time.
Here's an example of our previous ordering workflow that JS just spoke about. So what would happen previously is the physician would have to go in and manually enter 5 orders of the same at the dose required, the interval, and previously it was thought that this field here that stated for X amount of doses could be populated, and these would be waiting for the nurse to release them every time the patient presented. However, as JS stated, once the encounter for that visit was closed for the day, it canceled all of these orders.
So considering the issues of orders getting canceled, So we implemented the therapy plan. So once the therapy plan is in place, physician will be placing order for 5 doses of iron sucrose and will be signing it over. And nurse can release each order during each visit. So this order will stay as long as the plan is discontinued. So there will not be any issue in finding out the order, and there is no delay in releasing the order. So this actually helped the nurse in finding the order on correct time and brought down the ordering time to 5% versus the 25% previously.
Currently, we have 22 therapy plans available inside the Infusion Center. And the process for ordering is, at first, the physician simply looks under the infusion therapy plans and decides what he would like to order. So in this case, we'll be looking at iron sucrose. And he will then just simply interpret when he wants to start it and the department, just general information, and then assign the plan. And here he can also assign this to the patient. And you can see here, we've auto-populated this with what was required to build. So the iron sucrose medication is here, and the doctor can see that the order is there. And within that, he's able to click, we'll go back up quick, he can click on the SIG still right here and still get data where if he wants to modify the dose, maybe the patient needs a lesser dose for the visits or whatever he would choose. He's available still to modify that here, and that will be available. We do have pre-programmed in there, which we've found by much trial and error of what has worked inside of the Infusion Center. The order schedule is to be every visit, and the doctor then selects how many treatments that he would like here. However, down below in the order details, again in the SIG, this is where he can specify weekly, monthly, biweekly, whatever he would choose off of this. And this here will stay at 1 dose because this order here is actually the encounter-based dosing regimen that we see. And up at the top in this order schedule is where the amount of treatments will go. So that therapy plan will continue on until that number of treatments is completed. The physician then simply signs the therapy plan as he would any other order. And then when the patient shows up for their treatments, and also just to note, this doesn't have to be done on the day of the first patient's visit. The doctor can enter this therapy plan at any point in time prior to the patient even presenting at all to the infusion center. So it makes it convenient for him as well. So now when the patient would present to the infusion center, we can see clearly that they have a therapy plan listed under them. And we can see by this green check, the order has been entered, it's signed, and we then select Begin Treatment 1. So it's just one click to do that, and this is after the nurse assesses that the patient is suitable for infusion, of course. Once we select Begin Treatment 1, the order comes up in green. We click Select Orders, and we then select Release. And as simple as that is done, once the release button is clicked from our side in nursing, it is now immediately available on pharmacy's side to see, okay, we can now start preparations for this medication. And that's where the biggest lag of time was occurring, was the nurses were waiting for that order to be releasable, and hence pharmacy couldn't, of course, prepare anything until they had the order. So that was bound to be, as you'll later see, in our biggest time frame of wait. Now the medication shows up on the MAR as it should be, and the nurse can proceed with her barcode scanning and administer the medication once it's received by pharmacy. Once the patient's done, the nurse goes up into the actions, and you can mark the day as completed, and then the next time they come, it will show the next treatment too that's available for the nurse. If she should forget to mark that as completed, it will auto-complete at the end of the day. Value derived from this was that we had patient satisfaction improved due to reduced length of stay in the infusion center. We had efficiency of recurrent order entering improved. We had time from patient check-in to medication completion significantly decreased. and we had relationships amongst caregivers enhanced as practices became more clinical versus task-driven. Physicians were happier due to less ordering time, documentation, and redundant phone calls from nursing staff when we were looking for orders. Nursing was happy due to now the availability of a releasable order upon patient check-in, as well as nurse assessments to the infusion center. And pharmacy was also happy because there were less calls coming to them inquiring where this order was and where medication was. So they had lesser call volumes to verify medication processing times. So looking at this first chart, this is our average length of stay. And with the blue line, you can see this was the time with therapy plans. But starting behind even yet, on the red is where we started with the average length of stay with patients before our therapy plans were implemented. So we had a visit here of 142 minutes total when we started prior to the therapy plan, and you can see in Q3 of 2018, all of our iron patients are with a therapy plan, and our length of stay averages 67 minutes. This resulted in a 53% reduction in length of stay since opening of the infusion center with the aid of therapy plans. The current agreed upon process between the infusion center and pharmacy is once again that the medication should be received and able to begin administration within 1 hour. With the current length of stay at 67 minutes from patient check-in to medication completion, this significantly exceeds that goal. This slide demonstrates our value derived with the patient volumes with iron sucrose. As you can see, when we first started in Q2 of 2015, we had only 20 patients that were receiving iron sucrose. This was immediately after operations started, and to be expected, volume starts low. And as you can see now, coming up to some of our peaks here, 510 visits in Q3 of 2017, and still going into Q2 of 2018, we have 286 patients that are on a therapy plan. So keep in mind that doesn't necessarily equal 286 visits because they could be coming weekly that month. So these are our volumes with patients on a therapy plan. And we have a significantly very, very few amount, as you can see demonstrated by the red, of patients that come in without a therapy plan. Most often, these would be patients that are receiving one-time only infusions, that there's no need to even go through the process of a therapy plan. It's a one-time dose. So our patient volume has grown exponentially since clinic activation, with most iron sucrose patients having the therapy plan present. And this also demonstrates the importance of speaking up regarding workflow efficiencies, even now, even when the volume was low, because it actually helped us to identify the problem and prepare for increased volume, as well as having an established, well-oiled wheel with ordering optimization. With this graph, we're going to look at the value derived with financials with iron sucrose. So you can see the red again. This is our finances that are received that are with patients without a therapy plan. And you can see again with the therapy plan, the financials, how they increase. Dollars is on the left and time is on the bottom. So with the efficiency of the therapy plan functionality, more patients are able to be seen, resulting in more revenue being generated for Cleveland Clinic Abu Dhabi. Some of our lessons learned. We definitely learned the importance of working collaboratively and having transparent communication amongst multidisciplinary teams. We learned how crucial it is to communicate effectively to drive positive and successful outcomes. We learned how vital the Cleveland Clinic Abu Dhabi Speak Up philosophy is to effectively identify, troubleshoot, and problem-solve issues. With the therapy plan implementation, there was much communication in which we went around and around to figure out what actually worked best. And some of this because it was new to even the IT team that was here with us at Cleveland. It was new functionality for them to even deal with the first time. So communication was paramount with this. We also learned the value of sharing information and promoting awareness of our own successes. And as Feder said, just with our training that was extensive, I mean, we shared information everywhere. We went to staff meetings for physicians to promote awareness of this. So this also helped to create good collaboration and physician satisfaction as well. This is also demonstrated by the extensive replication efforts in the outpatient clinic setting. As you saw on the slide previously, we went from one plan of iron sucrose, the most simple plan, it's one medication, to now 22 plans that range from the most simple to so complex, where we have pre-medications, we have multiple medications being administered as treatment. We have emergency medications available for anaphylaxis. We have certain medications that are, specifically for dose 1 or dose 2 onward. We have multiple complexities now arising from this. We also have moved this into the outpatient setting. So clinics that don't do infusions, that have other things to be providing to patients, is done as well. So we have incorporated these therapy plans. We now have 21 available into the rest of our ambulatory settings. And you can see vaccinations are included here, routine vitamin injections. We even have BCG on here, which our urology department does as a procedure with their bladder cancer patients. So this actually is quite an effective regimen, not only for Infusion Center anymore, which is amazing. We have also recently just added a new therapy plan as we're implementing outpatient dialysis. So again, we have an extremely complex regimen that's being implemented procedurally for outpatient patients coming for dialysis that is the same treatment every time. We do have an action plan for continuous improvement, and that involves continuing to develop therapy plans based on voiced needs from clinics. And I myself just submitted a request for a new plan last week to FEDER here. We also are working to automate charges for simple therapy plan administration. And once again, iron sucrose, because it's a one CPT code billing initiative for that, it will be the pioneer. We have also working to develop a detailed automated pre-authorization management process in which, when changes are made to therapy plans, it then drives a notification to our authorization team so they can then work to change authorization guidelines if needed with the companies. And changes may also include to increase in dosing, adding or removing certain drugs and labs, combining therapy plans, and adjusting intervals. For a summary recap, our problem statement is that the problem was identified soon after clinic activation, that there was no effective computerized ordering process for recurring infusion treatment. Our solution design and implementation is that therapy plan functionality was identified and was successfully researched, designed, tested, validated, and implemented. And this resulted in a reduced patient length of stay, improved opportunity for revenue growth, and due to therapy plan functionality, the relationships amongst caregivers subsequently improved. And I think that our implementation and innovation shows that no small effort goes without a big reward. We had one small little plan ended up with a large volume of patients. So one change makes a big difference. Thank you.
Okay, we would like to thank our speakers from Cleveland Clinic Abu Dhabi for joining us today. And we would like to remind our listeners where to go find Davies use case webinars and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is hims.org/Davies. Thank you for joining us.